Hello, beautiful people. Welcome to another exciting Friday on PM Personality Profile. My guest tonight, and I am so excited because you know, when I sit with ladies, I become overly excited. Don't blame me, it's the woman thing. And so today we're going to be having the girl talk, if you like, woman talk. My guest tonight, she is a senior perineal midwife, one of the few you can get around the world. She's also a lecturer and the founder and director of the Peri Health Ltd. Adelaide, Esi Aduboffour.
That's right.
I'm so excited to sit with you. How are you doing?
I'm good. I'm also very excited to meet you. I always watch your programs. I never imagine I'll ever meet you face to face. So I'm extremely excited to meet you today.
I'm so pleased that we met today. Yeah. Let's start this conversation on a very beautiful note. There's so many nurses who are leaving the country for one reason or the other. How does that make you feel as a nurse?
Well, I have mixed feelings about it. It's a big brain drain to the country. If all the skilled people, after their training, the investment that the government has put into their training, and then after that they have to then go and give it to another country, that is quite a challenging situation. Having said that, I can understand why they are doing that. For the economic situation in the country is not that easy. I've been here for a week and a half. When I was coming, I thought I was quite loaded, but my money is almost finished. So anytime my sister asks me for anything, initially I was laughing, but now I was beginning to scream at her. And I'm coming in with pounds, and I'm still beginning to feel the heat. So you can imagine. Yeah. So they are going for a reason to try and get that greener pasture to be able to come and support their families. So that is the positive thing. But having said that, going into UK, yes, it has its positive, but the challenges over there, for example, the culture there is different, even food is different. Now they do have Ghanaian shops there, but it's never like if you are in your own country. The weather, for example, before I came, I know it's, you know, the weather is changing from winter, but it sometimes feels like you are in a freezer. It's freezing. You come out and your car is, you know, covered in ice. It's not easy. Whereas here, yes, it's hot, but you can still get the breeze and all that. So it's not all the nurses, if they have the right resources, would like to travel. So if the government can help in a way, you know, for example, I remember years ago when I was training as a nurse, you know, basic things like gloves we didn't have. So if they can provide resources and they can do something about their salaries, I'm sure there are many of them who wouldn't like to travel. The positive side is, I don't know if you've heard about GDNA, Ghanaian Nursing Diaspora Alliance or something like that. Yeah, so it's a new organization or alliance that's been formed by one lady and her counterpart. Her name, she's a professor, a Ghanaian born as well, professor who is based in the United States. And she's formed this to bring all Ghanaian nurses who are in the diaspora together to come back to Ghana and give back to what they've learned. So in a way, they are traveling and it's like a brain drain, but the positive side is, if they learn any new skills, they can bring it back to the country. And that is how I got hold of Yvonne Commodore Mensah, who is the professor I was talking about. She connected with me, and then we had a collaboration with Peri Health for me to come and deliver the training in Ghana. That's a positive thing. If people can go and learn and come and give back to the country. Also with regards to the economy, anytime they remit their families, some people are coming back with the money to come and start projects, build properties. That's all good for the country. Some of the few things that I've achieved, if I was a nurse or a midwife in this country, I could eat a whole bag of gari. I don't think I was going to be able to achieve those things. So in a way, it's good. And I'm able to support my friends and family. So that's the positive side.
You practice in the UK.
Right.
Did you have to leave the country because of working conditions or salary issues?
Not really, actually. When I completed my nursing in '94, that's when I met my husband, and he was at the time going to Swaziland. So immediately I finished my 1-year orientation, I joined him. So I went to Swaziland first before I came to UK. because of marriage, not because of the economic situation. But I'm not going to deny that if I had the opportunity to travel even much later down the years, I wouldn't have.
Okay.
So,
so you by 1995 you had left Ghana.
That's right.
And you were working in Swaziland.
That's right. And
you say the conditions were different.
Yeah.
In terms of your career.
Yeah, in terms of the career, the Ghana system, I appreciate it because when it comes to anatomy and physiology, learning about the human body and how it functions, I would say Ghana is excellent. You know, that gave me a brilliant foundation. Having said that, I think we didn't have much resources as in the, you know, Western world, or even in Swaziland. Swaziland is Africa. For example, there were certain instruments or equipment that were shown to us in textbooks.
Okay.
That I only saw them in textbooks and had never seen it before.
Okay.
It's only when I went to Swaziland and I was appointed as a theatre sister that I saw some of those equipment. I think in the simulation center, I was just a classroom with a few bed sheets, and you know, there was this solution that we used to we use it for mouth care. It's called glycothymolin. It's in Swaziland that I saw plenty of them, or even some of the special retractors that we use for surgical procedures. So, oh, okay, this is what was in the textbook. Now I'm seeing it. Oh, that's glycothymolin. Oh, interesting. So yeah, they had much more resources than we had at the time in Ghana. So it was quite interesting. But to be fair, I worked in a private hospital, which was accessed by a lot of affluent people. So I really can't speak for the Swaziland government hospital, but definitely where I worked, it was quite good.
So by 2000, you had left Swaziland to the UK. Why did you leave Swaziland?
Yeah, I mean, I've always been interested in, you know, exploring and learning and advancing myself, or improving myself. I didn't think Swaziland was going to give me that, meet my expectation to that level. Even though I did my midwifery, when I left Ghana, that was when I did my nursing. I did my midwifery in Swaziland, but I felt like UK was going to be able to give me more. And there was a big recruitment drive at the time. So I took advantage of that. They were recruiting a lot of nurses from South Africa, Swaziland, to the United Kingdom, to the US and Canada. So I was very attracted to go to UK, so I did.
Perineal midwifery. What's that all about?
Okay, so perineal midwifery. First of all, just for the benefit of those listening to us, they may not understand what perineum is, especially if they are not midwives or obstetricians. So the perineum, we all have it, both women and men. So the perineum is that space between the entrance of the vagina and the anus. So that is your perineum. So for the men, it's between the anus and the base of the scrotum. That's that space. Now, when women are coming to have babies, as the baby's head is crowning or coming out, the perineum stretches and it becomes quite bulky, like, yeah? So when it stretches, it becomes quite vulnerable when that baby's head is about to come out. And that is when the woman is at risk of tearing. And sometimes when that baby is tired, and even if the woman isn't going to tear naturally, we also give a cut, what we call episiotomy. And when you give that cut, obviously, automatically, you've caused injury, or she can naturally have that tear. So when they have those perineal injuries, we have to suture it or stitch it up for them. And it doesn't come without complications. So some of the women will end up with maybe infection, not surprising because of the mere location of the place. She's weeing, she's pooing, and that can easily be contaminating the wound. So they can get infection, maybe 4 or 5 days down the line. They can end up with the stitches getting opening. Sometimes, depending on the circumstances, either lack of skill of the clinician doing the repair, or maybe if the woman is bleeding profusely and they want to make sure that they stop the bleeding to save the woman's life, the woman can end up with anatomical misalignment of the perineum or the foresheet, the entrance of the vagina, which, and sometimes they can even suture and kind of narrow the vagina introitus. And this can result sometimes in skin tags. It can result in the vagina getting too small. So the woman can end up with sexual problems. So the infection, misalignment, skin tags, sexual dysfunction, all those issues were being swept under the carpet. So that is how this role of a perineal specialist midwife came in.
Okay.
So I have the clinical bit where I'm running the clinic, and I have the training bit where I run the workshops to give feedback from my clinic, for example, the case studies, and also train the midwives and junior obstetricians to make sure that they assess properly, they are able to pick up any complications at delivery, and also they are able to repair correctly to reduce morbidity for the women.
So in 2014, you set up the Peri Health Ltd?
I was a labor ward coordinator, so somebody in charge of the labor ward who supports the midwives and sees to the smooth running of the unit. And sometimes you go in and you notice that either the midwives are struggling to repair, and sometimes women will come to the triage. Here maybe they'll call it outpatient or accident and emergency with all these complications. And I'm particularly very passionate about sex, not just sex, good quality sex. And I know that if women are having all these complications, particularly what we call dyspareunia, which is painful sex, they are not going to be able to enjoy their marriages. So this is the reason why I got particularly interested in running the perineal clinic. I'm very much interested in making sure that I reduce morbidity for women and women's well-being in general.
And so far, how has the journey been? I mean, was it worth the sweat?
Oh, definitely. It's been incredibly rewarding for the team that I work with at the hospital. Before they didn't have my role, if these women present with these complications, it wasn't, they were not receiving that continuity of care from one person. They will come to triage. Some of the women will be referred to their general practitioner, which we call the GP. Some of them may see a gynecologist. They may be on a long waiting list and still be suffering like that. So now that the community midwives or even the midwives in triage or in the delivery suite know that they can refer women to me straight away, they feel confident that if we encounter any challenges or if we have any problems, we know who to go to. And also with the women, it's been incredible. It's been with some of the minor surgical procedures that I do, restoring their vaginas for them so that they can go back and enjoy their sexual life. I do get all that positive feedback and the appreciation from the women. Invaluable.
Okay, let's get into your expertise. I mean, the areas that is your passion. You talk about women and sex, and you also teach female genital mutilation. Let's start with female genital mutilation. I mean, what has your readings around it uncovered?
So with the female genital mutilation, for example, when I was at University of West London, I was leading on it and teaching the subject. So I read extensively around it, and for the purpose of this interview, to just summarize it, it's harrowing. Female genital mutilation has no place in society. Unlike perineal trauma that we are even trying to prevent, which is as a result of childbirth, female genital mutilation has no health benefit. And it comes in there are 3 types, or now it's 4 types actually. So the type 1 is where they remove the lady's clitoris, called the clitoridectomy. Now, somebody may feel it's just type 1, but the clitoris, there are other parts of the vagina that can still give sexual pleasure, but I will say the clitoris is the woman's powerhouse. That is what during sex makes you forget your middle name, you know. And that's what gives you the orgasm. So if they've taken your orgasm away, they've taken your soul away. So that clitoridectomy is unacceptable. And then sometimes they can remove the labia, so the lips, the inner lips. Okay, so that is the type 2. And then sometimes they remove the clitoris, the labia, and then they stitch everything until they leave a little hole where you can just pass urine. Okay, so there is no penetrative sex at all. And all this is quite cultural. It's the cultural beliefs of the people who do it for girls. And they give them all the reasons, the wrong reasons for that. For example, they want to make sure that the girl stays a virgin. It makes them clean because those of us who have clitoris are not clean enough. You know, they get a high bride price and all that. So this is what I say. Yes, they have those cultural beliefs, but the consequences or the complications are also devastating. For example, if somebody is going to get that clitoridectomy, it's not even done by a qualified person under anesthetic. And even if it's under anesthetic, removing your clitoris is unacceptable under any circumstances. So they do it under horrible conditions, contaminated, sharp equipment, so that can expose them to tetanus, that can expose them to infection, HIV and all that. Sadly, some can even have nerve damage, tissue damage. As they force the girls to do it and they struggle, they can even end up with hip fractures. They can bleed profusely, and sadly it can even result to death. And Aisha, do you know what? The youngest victim that I came across in literature was 3 months old.
Goodness
child.
Me.
So they have no way of consenting to it.
What do you recommend in dealing with this situation?
Like I said, it's cultural. And anything cultural, you can't just go and say stop it. Okay, so you need to be able to win the people on your side. So it has to be tackled in 2 ways, or shall I say the 2-pronged approach.
Yep.
So you need to kind of get the people on your side, educate them, and mostly this is kind of introduced by men. So if we can get to win our men on our side and explain to them about all these complications, and then we can tackle the women, the society, we can tackle the girls, the young girls as well as the boys. So if we can get the education through and get them to understand, then the government can also come in with resources. They can also come in with laws, guidelines and policies to stop it. But if the government just comes and say, yes, we've put in this law, stop FGM, trust me, it will look as if it's been stopped, but people will go underground. So it's education, getting them to change their mindsets, you know, and then the government coming in with the law as well. So with these 2 approaches, I believe that we can tackle FGM. It has happened. There was a girl in the United States from the Gambia, and then she did a big campaign about FGM, involving the government and then going to the community leaders to talk to them. And once she got the influential people involved, got the government involved and put the education in, the Gambian government implemented that law to stop it. And then I know she was saying that their last born, I think there are about 7 girls, all of them had FGM because of her campaign. Their last born, at that time she was doing the campaign, did not have the FGM. So with that approach, I believe it will work. It will work.
And so let's talk about sex and women. I mean, that's your specialty. What have you uncovered, I mean, throughout this 30-year journey?
Okay, so the sex and childbirth, at the time I actually published a book about it, was around 2010. And this is when anytime I went to see a woman antenatally, they will be asking me about, I like to believe that I'm very approachable. So the women were quite comfortable to open up. And then they kept asking me about, can I have sex? Is it safe? So straight away, I picked up that people had limited knowledge around sex and pregnancy. So I did a little research, qualitative research, interviewing the men and the women, you know, expectant men and women, or expectant couple about sex. And I was shocked with some of the things I discovered, the myths around sex. So some of the things that came up was, if you have sex during pregnancy, the baby is going to be promiscuous. Right. Some of them believe that the baby can actually hear you having sex whilst the baby is in utero. There was one colleague, actually a midwife, the partner or the husband wasn't a midwife, but he stopped having sex because when we're having sex, the baby was moving. You know, the baby is moving doesn't mean that the baby can hear. The baby is excited, but it's oblivious. Okay. There was even one myth that if you penetrate the vagina, the baby can actually grab your penis. Right, that was an interesting one. So at that point, I said, I have to publish about this. I have to put in some education
there.
Yes. So this is when I wrote about sex, you know, when it's safe to have it. There are obviously other complications where, for example, some women suffer premature dilatation of the cervix when you are not fully termed to have the baby. So if you are going to have preterm labor, we would say don't have sex. If you are bleeding vaginally, we would say don't have sex during pregnancy. If your waters break, ruptured membranes, we would say don't have sex because of the infection. Other than some of these things, if we say low risk pregnancy, you can have sex. Again, it confuses people.
Yeah.
If they have things like high blood pressure or gestational diabetes, but that has nothing to do with the vagina. That has nothing to do with the cervix.
Okay.
So even though that's high risk, they can still have sex. But when we say low risk, as in if you don't have placenta previa, you know the placenta, it's expected to be in the upper part of the uterus. But in some cases, the placenta comes right at the cervix. In that case, if you have sex, you run a risk of the placenta separating. So with these risk factors, we wouldn't recommend. But other than that, with low risk pregnancy, they can have sex. So I had to write to kind of explain some of these things, and also to kind of explain and demystify some of these taboos around or the myths around sex and childbirth, and empower women if everything is normal during the pregnancy. Actually, having sex during pregnancy is a good thing because it prepares them very well for labor. Yeah, the thrusting helps to stretch the muscles. I noticed that when women come into labor, those who are sexually active, when we are doing vaginal examination to check their progress, they are much more comfortable than those that, as soon as they see the clear blue positive and pregnant, stay, you know, they put the no enter sign to the husband, stay away. Those ones struggle a bit when they come in and we do the V's, but yeah.
Adelaide Esi Aduboffour, she's my guest tonight. I told you we're going to have a girl talk. I'm sure you've been enjoying the conversation. I am enjoying the conversation. She's one of the very few perineal midwives you can find around, and she's been telling us a lot about women, childbirth, and sex. When I return from this break, she'll be telling us more about herself. We'll be getting to know her better. She'll be sharing her growing up with us. She would also be telling us about her values and lifestyles. I would also be picking her thoughts on what she recommends as solution to the exodus of nurses we're witnessing currently in the country. Stay with me. I'm coming right back. Welcome back to PM Personality Profile, and my guest still Adelaide Esi Aduboffour, and we've been having some interesting conversations here. Before I get into your skin proper, I want you to share with me some of your challenges whilst in Swaziland and in the UK practicing as a midwife.
Right. So in Swaziland, I didn't start as a midwife. I started as a nurse.
A nurse.
And there it's if you are just a registered nurse, they call you single qualified.
Okay.
And if you're a nurse midwife or you have other qualifications, then you are double or triple qualified.
Okay.
So initially when I got there, I was obviously single qualified. And so one time I went to work. I've always wanted to be a midwife though, because it's my passion. My mom is a nurse midwife and she's my role model. So I've always wanted to be a midwife, but at the time I was a nurse. So one time the nursing sister in charge assigned me to look after a particular bay of patient. But I knew I was going to church there. So one of the eldest wife, who I knew very well, had come to have a baby. So I said I was going to say hello to her. Aisha, the embarrassment from that senior sister. Go back to your bay. You are not a midwife. You don't have any place here.
Oh my God.
You know, technically, I mean, I'm not quoting her, but that is the message that she gave me.
You.
And in front of the woman, I felt so embarrassed. I walked away. You know how sometimes people mess you about or whatever, they mistreat you. You must always take the positive out of it. My friend always says, if they give you lemons, turn them into lemonade. So I turned the embarrassment right into positive for me. I went home that evening and I told my husband, listen, I'm going to do midwifery. And said, what's up? Said, I'm going to do midwifery. But you are not a Swazi, you have to pay school fees and it's not cheap. And I said, it's going to happen, I'm going to do midwifery. So and yes, it was expensive, but somehow we managed to find the funds. And I went into the University of Swaziland to start my one-year midwifery program. And that didn't also come without a challenge either, Aisha. So as part of the midwifery program, we had to do research. And there was this research lecturer. She was very good, but she would teach in English all right to start with. But the examples that's supposed to help you to understand what she's teaching. So for example, she will explain something like randomized control trial, and then to give an example to make us understand further in Siswati. I didn't understand the Siswati, so I started hating research. So a time came round that we were supposed to do a test or a mock before our final exam.
Okay.
So that mock came, Aisha, it was 20 questions and I got 1/20.
My goodness.
I remember recently when I celebrated my 50th birthday, my daughter was putting my lifestyle story together. So when it got to that bit and I told her about the story, because I said, Woma, 50 years, it can't all be positive. Yeah. There are negatives there. Definitely. So I told her about this research situation and she said, Mommy, you got 1/20? Now that's brain damage. That is brain damage. And she said, okay, I'm not going to put 1% there. I'm going to put 10% for you. Even though the 10% is still bad, but at least
it's better than 1/20.
It's better so that was it. So I remember coming home crying, and then my husband is quite academic and very supportive. So he took all my textbooks, my notebooks. He stayed through the night to study it.
Oh,
to study it.
That's lovely.
And then normally when he tries to mark my work, and when you give your work to him, by the time it comes, you know, with the red pen, the whole black pen has turned in. So I never like giving my work to him anyway, because I don't want that. And sometimes I'll be answering him back. And this time round, my tail was in my bum, all polite, help me out. So yeah, he sat me down, took me through all the research points, you know, explained everything to me, and thankfully I did pass. So that was one challenge there. Language was also a big barrier. I have to say I was fortunate, because in that private hospital, most people spoke English, but you get the occasional people who wouldn't speak English. And the midwifery training was actually in the government hospital. So most of the women couldn't actually speak English. So I remember some of the things that you really need to know, because if you need to do a vaginal examination to assess the progress of labor, you're going to have to communicate to the woman somehow. And you don't always have a Swazi midwife or somebody else next to you to translate. So you have to figure some body language and all that, sign language. So there is one phrase that I learned and learned very well. Kumula panty. Lala begetulu. So kumula panty means remove your pants and lie on your back.
On your back.
So that phrase, if you're a midwife or a gynecologist in Swaziland, you had to know that phrase. So that's, but I did have some basics like unjani, unkona, nyapila.
What is unjani?
So unjani, how are you?
Okay.
I'm fine, unkona.
Okay.
Or if you say, so the way we say etsay in Ghana, instead of saying mehoye, you know, so instead of say, so with the nyapila, it's a quick way of saying a yeah rather than mehoye. So unjani. Okay. And then you say unkona or nyapila, you know, so yeah, the language.
Okay. But at least you were able to sail through. Yeah. Let's talk about you as a person, Adelaide Esi Aduboffour. Your parents are from the central region, right?
That's right.
Is that where you were born?
No, actually, I was born at Akimtafo in the eastern region. Okay. So Achimbremu. Is what I was drinking.
But where precisely do your parents come from in the central region?
My parents are Fantis.
Okay.
My maiden name is actually Anderson, so Aduboffour is obviously my husband's name. And my dad told me that originally his mom came from Salt Pond, but he got married to my dad's father, who was from Aguna Nyekrom. Okay. So I would say we are now from Aguna Nyekrom because that's where they resided. Okay. And my mom is from Ewutu Breku. You know that Winneba, is it the road to Winneba? Sure. Yeah. So my mom is from Ewutu Breku.
Okay, but you were born in Tafo?
I was born at Akim Tafo, all of us, yeah.
Okay. Okay. Tell me about growing up in Tafo.
I would say, well, I'm the last born, so I was spoiled.
How many were you?
I'm the last born of 5 girls.
Five girls?
Okay, not all the 5 girls come from my mom. So my mom's first daughter, and then my dad also has the 3 on the side. And then, so coming together, we are 5 girls.
Your father must have bought a gun.
Oh, yeah.
To have 5 girls.
He couldn't shoot out a boy, you know. Actually, he did. My only brother.
Okay.
Yeah. My only brother, he came before me, but apparently when he was born, in less than 48 hours, we lost him. He had what we call intracranial bleed. My mom told me about it. Again, that is one thing that inspired me to become a midwife, because I wanted to find out what caused that and how that can be prevented and also support women. So yeah, he had that. So yeah, we had one brother, but we lost him. I remember when we were quite young, my dad was a junior officer in the Cocoa Research Institute. So we lived in the quarters. And that kind of facility was good because we had a shower and a good toilet and all that, good facilities. And then somehow he decided to go private. So going private means he had to leave the quarters, because you can't live there if you're not working for them. So when he went private, we had to come to town. And yeah, I quite liked the building, but to be honest with you, it was waterlogged. And it was in a bushy area, and the facilities were not the same. We didn't have the shower anymore. So we had to kind of wash from the buckets. And I said it was a bushy area, so there were snakes. So that was quite tricky. Sometimes you would just be coming from town, and as you enter the house, you see a snake passing. So that was quite scary. And my dad was scared of snake. I remember one time there was a snake passing, and then I said, "Dad, that's the snake." And he pretended that he wasn't seeing it. Where is it? Where is it? Where is it? Where is it? Before we knew it, the snake was gone. Anyway. But apart from the snakes and all that, as children will always be children. So we made the best out of it. I remember sometimes at the back of the house, we would just mount this Pampro sticks and then put some nails in it and then put the sticks across to do the high jump, and then we would play, and you know, we try to make the best out of it. But my highlight was actually my primary school, Creek Primary School, the best primary school in the country.
Tell me about it.
Creek Primary School, I loved it. Can you believe that to date we have a WhatsApp group as primary school mates? We still communicate, we celebrate birthdays together, funerals, support each other. It's the best. So I'm still on that primary school platform. It was a good school. It gave me a solid foundation as a child. The ethics, the good behavior, everything. You had to cut your nails, make sure your uniform is clean before you go to school. The bits that I didn't like was the mental, because I wasn't academically strong, you know. The mental.
Early morning.
Every morning mental, and if you don't get it right, you get a whip. And also, if you are late in school, you get a whip as well. And then at the end of the term, they bring the whole school together. And then from class 1 to class 7, they will just call the result out. So by the time number 15, you are not there, you know, you are somewhere 20-something. And coming home, you are scared to come and show your results. But then the good thing there was, we used to have this inter-sports competition with a school in Koforidua called Madonna. That was good.
That was at the B.
Yes, at the B school. But then they will come to us and we'll go to them. So anytime they would play netball, table tennis, anytime Madonna was coming to us, I didn't really like it. I wanted us to go to Madonna. It means that we're going to travel to Koforidua, and it was such a big thing. It was as if I was going abroad. And then going, you get your packed lunch as well. So that was good. And another positive thing was our day. My sister is a caterer. She always liked to cook anyway. So our day, the whole year, you don't eat chicken and jollof. So our day has to happen so that you can eat something.
Jollof
and your chicken.
And that's when, I mean, other kids also bring
their food, and then you go. I remember one of the friends brought this green rice, and we didn't understand it. And now I know that it was colored. But at the time, say, "Whoa, she's got green rice," and we're fascinated. And then I know some people as well. This time, kokonte is, you know, a delicacy, right? But at the time, you know, kids, they are horrible. And then somebody will bring kokonte, and they will be laughing and say, so they'll cover it because it's kokonte. But now it's a delicacy, and I would love to have it. So yeah, it was fun. It was fun.
And then so from Creek, you to Oforipenny.
Yes.
How was the experience there?
Oforipenny was great.
And that's where you did your O-levels?
That's where I did my O-levels. And before I went to Oforipenny, actually, because most of the Creek primary students, the girls, most of them went to St. Rosie's or Ebri girls. I wanted to go out of Tafo and be, you know, and be in the boarding house. But my dad won't let me. My mom was a school nurse at Oforipenny. But you know what? Oforipenny You know, I will go there again and again and again.
Okay.
The only thing I didn't like was being a day student. I also wanted to be a boarder, and I was so desperate. You know, when you are those in a boarding house, some of them will come from Accra, and they were speaking Ga, and oh, the Ga language is romantic, Aisha. The Ga language, I wanted to learn it. So I wanted to be in a boarding house and be autonomous, because as a day student, you come home, oh, fufuna bill, come and pound,
wash it, dishes.
Come wash the dishes, washing the clothes during the weekend. I wanted to skive all of that. But then, having said that, if you are in Form 1, the boarders were also struggling with homeowing.
Okay.
So I guess I can't win it. And not going to the boarding house, my dad, who is very strict and overprotective, I would say, maybe he was a bit worried that if we went to the boarding house, the boys were going to do things. So stay at home, let me keep an eye on you.
Were you a bad girl?
No, not really. I was crife.
Okay.
I was super crife.
Tell me.
You know, I was in a Catholic church because my dad was a music director there and a catechist. So I was in a Catholic church, and then around Form 3, we became radicals.
Oh, okay.
Now that I'm matured, maybe I would have managed things differently. We became radicals. So you know how you go to the Catholic church is Mo Maria, Dumasha Oma, Unyameka. So if you're a teenager, you know what? It's like you're sleeping. I want something more exciting. So we kind of were all sucked into Assemblies of God. And that is where my chaos started with my dad. The catechist, you are not going to embarrass me to go to Assembly. Yeah, I'm also me, and you are not going to answer in heaven for me.
That's what I want to do.
So that's what I want to do. And my auntie was saying, now you've produced a daughter like you. You are tough, she's tough, and you are clashing. Yeah, so I couldn't wait to finish the Form 5 so I could just get out. I remember when I was choosing my nursing school, I wanted to get a school in Jirapa or Kamani somewhere so that I can completely disconnect from him. Then my mom said, after the first year, if you need food or any support or any problem, who is going to come to that far?
Okay.
So be sensible about it. So I tried Kolebu. I didn't get Kolebu, and then fortunately my mom trained at Cape Coast, so I got Cape Coast.
Okay. Let's talk about the nursing training school. That was also fun?
Yeah, it was.
At that point, you had your freedom.
I had my freedom. You know, with the nursing, as much as because of my brother who I lost, I wanted to do nursing.
Yeah.
At some point when I finished Form 5, I wanted to actually go to A-levels because all my friends were doing the A-levels, so it was kind of cool.
Yeah.
So I wanted to do that. And then my sister was insisting, no, you are not going to. She wasn't even suggesting. She was insisting that, no, you are not doing that. You are going to nursing. So anyway, I went to the nursing, and I was all excited because for the first time I was going to be independent on my own.
Okay.
And then the course started. There's something called prelims. The first exam that you do before you can progress. It's so intensive. But thankfully, we passed, and then we progressed to year 2. There was this lecturer or a tutor called Mr. Finn, may his soul rest in peace. He was excellent in surgery. Okay. And so one time he was teaching us surgery, and he said, I'm going to take you somewhere this afternoon. Okay. So go for lunch, and then maybe 2 o'clock, meet me at the hospital. Okay. So we're all excited. Where is he going to take us? Where is he going to take us? Followed Master Finn, and I'm thinking, is that not the mortuary we are going? Aisha, truly the man was leading us to the mortuary. I said, okay, let's see what that brings us. We went to the mortuary. There has been a nasty road traffic accident on the Takrady Cape Coast Road, and this guy sadly had lost his life. So they were doing autopsy or postmortem. So with the postmortem, they wanted us as students to understand and see the anatomy, not in textbook, but as reality. It is in real life. Wow. So first of all, with the autopsy, they actually opened the abdomen and take all the intestines to see whether there was any internal injuries after doing the external physical assessment. So I thought, okay, I can handle this, right? And by this time, 2 of my colleagues had collapsed. And I'm still thinking, yeah, I'm brave, I can do this. And the next thing, he took the hammer and the chisel. I'm thinking, where is he going with that? To the skull. They had to open the brain and see if there was any intracranial
bleeding. And they used hammer and chisel? They
opened the skull. And then he was so relaxed. This surgeon called Dr. Odu.
My goodness.
He was talking us through. So this is the biparietal bones. This is the what was the brain he was describing. At this time, I was feeling dizzy. I was feeling so I just rushed out, you know. And that was a Friday. So after this session, I rushed to the station straight. At that time, my mom had moved to Swedru, straight to Swedru, and said, "Ma, it's over. I'm not doing any nursing. Find some teaching course for me to do." She just looked at me and said, "That's fine. It's normal. You will get used to it." So this was Friday, and I'm thinking I'm not going back. By Sunday evening, he says, "Oh, it's getting it's getting to 2 o'clock. When are you going?" "You get back and go. It will be fine." But yeah, so I went back. And the rest is history. I really enjoyed Cape Coast NTC.
We've talked about school in Swaziland, but you also had the opportunity to study at the Thames Valley University of London, St. Mary's College. You said the Thames Valley is the same as the King's College, right?
No, the Thames Valley is now University of West London.
Okay, University of West London, but you also had the opportunity to study at the King's College.
Right.
Share the experiences with
Right. So with Thames Valley, when I came from when I came from Swaziland to UK, I started with nursing.
Okay.
But I knew as much as I was enjoying my nursing, midwifery was also my passion.
Yeah.
So after practicing nursing for about 3 years, I decided to embark on my midwifery course. So through the current hospital where I work, West Middlesex Hospital, I applied. They were recruiting, looking for midwives, looking for people to start the midwifery course. So I applied, was successful, and I started my midwifery program there.
Okay.
It was quite good in a sense that because I had done midwifery, the diploma in midwifery in Swaziland, in terms of the anatomy and physiology, it made it quite easy. But the bit that I was lacking was the psychosocial care.
Okay.
So it was really good because some people do come from Ghana and do what we call adaptation.
Okay.
So they don't necessarily have to go through the formal midwifery program, but they then do an adaptation on the ground and maybe do a few top-ups from the university. But I decided, no, I'm just going to do the whole 18 months program, and I did. It was intensive because at the time I had kids.
Okay.
I had to go through about 3 au pairs, house helps, to be able to do this course with an incredible support from my husband. One time I came from uni and the au pair had stolen everything and left.
You're kidding me?
Yeah.
Wow.
So there were tears. It was difficult, but I was so determined and I did it.
Oh, wow.
So from there, I stayed in the hospital and I've been working in that hospital since. You know, so up until 2014, I decided to then go into academia. So I was doing part-time at the hospital, a couple of days, and then 3 days at the university.
Okay.
And then eventually I increased my hours at the university to 4 days and just sticking to the perineal clinic a day.
Okay.
And now, because of the demands for Peri Health, which is also teaching, I believe in doing, not kind of juggling with too many balls. So I had to drop some of the balls. And because Peri Health is also teaching, I decided to drop my lecturer role now and just focus on the clinic and Peri Health.
Okay, so how many kids?
I've got 2 girls.
2 girls.
2 girls.
And you had to go through all this to have them.
Child care in England. It's not a joke. But if you have a very supportive family network and support system from friends, it can happen. You know, they can support you.
I know that in London or even in the US, mostly people are concentrating on their jobs, from work to home. I mean, mostly they say if you want to stay safe, always be in your room, don't go roaming about and all of that. What do you do to relax after a hard day's work?
Hard day's work. Well, I've been in London for 24 years now. Okay. So, and having colleagues, you meet friends there. So as you meet friends, you get to know people. So it's not that bad, at least from my perspective. It's not that bad. I've got some friends. Okay. That occasionally there will be a birthday party or an event that they will invite you. And myself, I like organizing events to educational event, but fun at the same time. So we do that, but it's not that often. And I have to say, because I'm incredibly busy, sometimes I don't get the time to go. So I have friends that I've lost because they feel I'm too busy. When they invite me, I don't come, I don't call them, so I've lost them. But that's okay, because the friends that if you don't talk to, But when you pick your phone 2 years down the line and you call them and it feels like you just been talking 5 minutes ago, those are the ones I've kept and they are very loyal.
Okay.
So I don't have many friends, but the couple that I have, they are incredibly loyal.
Okay.
But coming back to your relaxation, I like things like massage,
okay,
aromatherapy, listening to relaxation music. I meditate a lot, and I reflect a lot, and that is when all my innovations come from. Yeah. So when I'm in my own space, turn off the light, you know, relaxation music. And when I'm not doing that, I like to go to the YouTube a lot. So you are in Ghana, but you'll be surprised I have a lot more info about Ghana than you. The politics and everything going on. I'm listening to the bloggers and all that. Okay. So yeah, I do that.
Okay. As a nurse, I'm sure you also keep fit sometimes.
Yeah, I do. It's not easy though, because sometimes you put on the weight because of stress. I remember when I was lecturing, we mark into late in the night. Oh. And you have to come for it. Or even as a midwife, if you get a very stressful shift, before you know it, you are just picking and then you put on the weight. But over time, it's become inevitable to try and curb the weight. So as I said, I've yo-yoed the weight, but recently I focused and did an intensive weight loss program. I did an intensive weight loss program. I remember last year when I came to Ghana, I was about 92 kilograms. And I said, no. When I looked at my pictures, I felt like a whale. It's like, you cannot be educated and be that big. Come on, do something. That's what my friend tells me anyway. You know, I mean, if you're a healthcare professional, how can you tell people to keep fit when you are not fit yourself? You know what? It's like the pastor saying, listen to what I say, but don't do what I do kind of thing. So I embarked on it, and all I did was reduce carbs. Okay. So I reduced carbs, and I also tried to do some exercise 3 times a week. And on weekends, we do a good 10K walk. Okay. So that's what I do. Okay. Do you listen to music sometimes? Oh, yes. I love music. Okay. I love music, so I do listen. But I like the gospel music a lot. I listen to any genre, but gospel music. Gospel music. Do you have a favorite? Yeah. I have lots of favorites, actually. Diana Hamilton, Joyce Blessing, Obapa Christie, all of them, really, all of them. But my Uncle Ato, but my favorite one that inspired me when I was setting Peri Health, it was so challenging. It was so challenging. You know, when you're doing something and you don't even know if it's going to work, but you still hope and believe that you keep going and it will work. So in my very difficult moment, it was Selena Boateng's song that put me through. Okay. My Lord who be God, He will accomplish it. My Lord who be God, He will accomplish it. He's the Alpha and Omega. Okay. The beginning and the end. He will accomplish it. He will accomplish it. Alpha and Omega, the beginning and the end. He will accomplish it. He will accomplish it. Thank you so much, Adelaide Esi Aduboffour. Thank you so much. I've really enjoyed talking to you, and I'm so proud of your achievement. Keep supporting women out there, and God will bless you. Thank you. Viewers, thank you so much for watching. Same time next week, I'll be bringing you another interesting personality on PM Personality Profile. My name is Aisha Ibrahim. Do enjoy the rest of our programs.